bag for you. So I will, so this was the history. This was a 3-month-old boy with abdominal distension, and a mass was detected on ultrasound, and then CT was done for the patient. So I'll be showing this time, I'll be showing you the case as a whole. So we have 4 phases. We have the non-contrast phase. Uh, we have 3 more phases. We have arterial, hepatic, and we have a delayed phase. So let me just open the chat box also. Right. So we'll start with the case. So what do we see here is basically, I hope all of you remember, this was a mass which was normally iso to hypodense, and it had few areas of hyperintensity within it. As we can see on this non-contrast, there are some areas of hyperintensity, and this was seen arising from the liver and was almost reaching up to the level of the pelvis. So on post contrast, we are better able to see what are the characteristics of the tumor. We have a large heterogeneously enhancing tumor, and I want all of you to tell me what are the markers of identifying whether it is arising from the left lobe or the right lobe. I'll just scroll it for you. So I'll just tell you first the basic anatomy that we are discussing. So as we go down, this is the IVC. These are the hepatic veins. And we are now scrolling down, and you can see that the mass has now appeared. And we have this heterogeneously enhancing solid soft tissue lesion. This is the portal radical. This is the stomach. This is the rest of the liver. Okay, so images are not visible. Okay. So I'll just share it again. Just wait.
Siddhi, we can see the cases.
Are you able to see the cases now?
Yes, we can see the radiant viewer open.
Yeah, and you can see the case, right? And the images.
Yes, it's in 4 divided columns.
Yeah, sure. So I was discussing about this mass lesion, which has few hyperdense areas within the liver and has few calcifications also, as we can see, and has a central non-enhancing component. We were trying to identify what are the normal structures that we can see. So here we started with the IVC, and we see the hepatic veins. As we go down, we can also see the portal radical. We can see the normal left lobe of the liver. I can also see that there is a gallbladder which is lying medial to the mass lesion. So I know that I am dealing with a mass which is located in the right lobe of liver. And as I go down, I again try to trace what is the entire extent of the lesion, and it is extending entirely up to the level of the pelvis. So what is the enhancement characteristic that we see in this tumor? So in the NCCT, we see that the lesion is almost isodense or somewhat hypodense as compared to the liver. On arterial phase, we see intense and not intense. It is a kind of a good enhancement within the soft tissue, and the central area, which we were suspecting to be a necrotic part of the mass lesion, is hypoenhancing or not enhancing. And then on subsequent phases, you can see that the contrast enhancement is fading, and this lesion is showing a washout. So as I told you, we were dealing with a mass lesion, and the patient's age was 3 months. So we have very little differentials in our differentials with us, and one important point that I want to highlight before we go further into the discussion is that you have to look at the mass effect. You know that the mass is extending from the subhepatic, from the subdiaphragmatic location to the level of the pelvis. And yet, because of this huge mass, you can see the condition of the right kidney. So this is very important in children, because in children, like we discussed the cases of abdominal compartment syndrome, even the large masses can have a similar effect. And if the duration of the mass effect or the mass effect is staying there for a long period of time, there can be some perfusion abnormalities in the organs which are compressed by the mass lesion. So these are some of the pointers that you always have to write in your report, so that the operating surgeon also knows that what is the urgency of operating a particular tumor and when we can leave the patient for next investigation. One very important point that I always discuss is that this is the aorta, as you can see. Do you see the size of the celiac artery in this patient? So if this is the small aorta, I'll just magnify it. So this is the small aorta that we are able to see, and you can see that the caliber of celiac artery is just small to that of the aorta, which is normally not seen in such a child, right? And when we go down, you can see that there is an abrupt change in caliber of the aorta. And why is this happening? So we are seeing an enlarged celiac trunk because the hepatic artery, you can see, we can trace from the celiac trunk, you can see that this is the hepatic artery, and it is seen to supply the lesion. So this is a very important pointer that tells you that the lesion is arising in fact from the liver, because the most common differentials in these cases is whether it is arising from the adrenal or it is arising from the liver, and secondarily it is involving the liver. So if you see an enlarged hepatic artery, you know that the particular mass lesion is being supplied by the hepatic artery, and therefore, because this particular small artery has to supply a large tumor, so the size of the artery always increases. So not just in children, even in adults, you will see that if whenever there is an HCC or you are dealing with hepatoblastoma, as I had already told you the diagnosis that this was an hepatoblastoma. So in these cases, you will always see an enlarged hepatic artery or enlarged common hepatic artery or an enlarged celiac trunk. The same finding that we discussed, that the caliber of aorta is narrow when we go distal to the celiac artery. This has also been described for infantile hemangioma. And why is this important? Because of the same reason, because infantile hemangioma has a lot of vascularity. So when you are trying to supply a larger lesion, you know that it will need a lot of vascularity, and the entire blood is almost focused to the liver, and that is why in those cases also you will notice that there is a change in the caliber of the aorta. Sometimes when the size of the lesion is not so much enlarged, you might not see such these changes, but again, always look for the size of the hepatic artery. And in the arterial phase, you will always notice that the size of the hepatic artery in comparison to the age-matched patient, in the case of hepatocellular carcinoma or in a hepatoblastoma, it is always enlarged, because these tumors primarily have an arterial supply. And that is why the hepatic artery is enlarged. So we all know that liver has three kinds of blood supply: hepatic vein, portal vein, and we have hepatic artery. So hepatic artery is the major supply of the tumor, and that is why even with the enlarged hepatic artery, when the tumor is not able to get the vascularity in the entire extent, this kind of necrosis always happens in between the tumor. So whenever necrosis happens, you always tend to find some foci of calcification. So the foci of calcification, as we had discussed in the previous case, that was a case of a neuroblastoma. So neuroblastoma has calcifications, we all know. So that is where the confusion arises when you see mostly in patients, when sometimes a single phase is done, a patient comes from outside, there is a mass lesion, there is a calcification, there is central necrosis, and now you are confused whether it is a neuroblastoma or it is a liver mass. So never get confused with a single foci of calcification. Neuroblastomas tend to have macro calcifications, whereas this calcification we see only in the necrotic part. The enlarged tumor, the entire part of the tumor, does not have any predominant calcifications. So again, as I always told you, that if you are still confused, look at the vessels. Most of the tumors, they will displace the vessels. If it is a large tumor of the liver, it will displace the vessels. Unlike neuroblastoma, that tends to encase the vessels. So all these cases are actually very commonly made a differential of each other, and that is why we are trying to learn that what are the pointers that we can say that a particular lesion is arising from the liver, or right, so arising from the liver or the adrenal. So this was, so again I'll go back to my slides. So this was the case, and now once we have seen the case, now I am going towards the differentials that we have. So I told you that there is a large mass lesion which has a heterogeneous enhancement. There is change in the caliber of the aorta, and just open the text box. Right. So these are the differentials that we have in the child, which is, a 3 months old child, and the large abdominal mass, and parents are also concerned about what is the origin. So now we are dealing with the liver mass, which there is a large soft tissue component, central necrosis, few calcifications, the hepatic artery is enlarged, and we have an abrupt change in caliber of the aorta. So now the first two differentials that come to our mind always is a hepatoblastoma and infantile hemangioendothelioma based on the the imaging apparatus. And that is what was the main doubt that the surgeon came to me with, whether it is an infantile hemangioendothelioma or it is a hepatoblastoma. And all this is happening when the AFP has not been done. This is the first time the patient has come to you, and we want to do something for the patient. So once we have something in our mind, we can send the relevant investigations. Like, for example, if I give you the two possibilities of hepatoblastoma and infantile hemangioendothelioma, you can tell me that if AFP is raised, it is hepatoblastoma. If AFP is normal, it is infantile hemangioendothelioma. This is a normal. This is actually helpful when the child is more than 6 months of age, because until 6 months of age, the maternal AFP levels are also raised, and that is why there is a confusion whether it is a spurious increase or it is because of the tumor. And your imaging will then help you. So hepatoblastomas, as I told you, was a solid arterial phase. They show arterial phase enhancement. They show washout. Sometimes they can show calcifications. If fat can also be seen within the hepatoblastoma, mostly the age is less than 5 years, and most cases occur less than 2 years of age. Even in the less than 5 years of age, the most common cases, they occur in less than 2 years of age. Mostly they are congenital, and the background liver, you will always see it is normal in these cases. Again, we all know AFP level will be raised. And infantile hemangioendothelioma, it occurs in the same age. The lesion shows arterial phase hyperenhancement and shows progressive fill-in, as we classically, tell for the hemangiomas. The calcifications, they can be granular or chunky. And the AFP levels, as I told you, depends when are we trying to diagnose. Sometimes the AFP level, they tend to confuse you, and I'll tell you more about AFP later. Again, in this particular age group, mesenchymal hematoma is a differential. However, most of the lesions, they are cystic in nature. And again, AFP will not be raised in a mesenchymal hematoma. So this is just a differential of this particular age group. The most important differentials is always a hepatoblastoma, infantile hemangioendothelioma. And it is very important because the prognosis completely changes for the patient. Infantile hemangioendothelioma can be given a trial of beta blockers, whereas hepatoblastoma, the patient will be sent to, oncology department. Then again, HCC is a possibility. Why? Because of the classical characteristics of arterial phase enhancement, we have a washout. But the age is mostly more than 5 years of age. And in those patients also, the background liver mostly has some kind of a hepatitis, or there is a diseased liver. So again, these are the list for the sake of completion. However, the hepatoblastoma and infantile hemangiopericytoma are the most common differentials. So this case, the AFP levels were more than 5,000. You should always, I'll just speak a few words about hepatoblastoma. So it is associated with many familial syndromes like Becton-Dickinson and Gardner syndrome. familial adenomatosis polyposis, type 1 glycogen storage disease, and trisomy 18. So why am I telling you this? Because hepatoblastoma, if you are getting a case of hepatoblastoma, you have to actively look for the signs and symptoms or imaging features or any clinical evidence of these particular diseases. If you are looking at hepatoblastoma and you miss adenomatosis polyposis, it is your fault. So these syndromes are actually going to help you. So type 1 glycogen storage disease is a very important a syndrome in which the hepatoblastomas are seen at an early age, and you should always look for them. Look for the the skeletal manifestations of glycogen storage disease, and trisomy 18 is again identified by the clinical features. So I'm just telling you because in children, diagnosing a hepatoblastoma is not the end of the story. You have to also look for any additional thing that you might miss, because we all have satisfaction of search, and that should not be the end in children. One important thing is that the prevalence is inversely proportional to the birth weight. So the more the child had the birth weight, the less likely the child is seen to have a hepatoblastoma. Then sometimes in some articles, it has been written that iatrogenic exposures of infants to neonatal intensive care like oxygen therapy, assisted ventilation, and furosemide therapy also predisposes them to the hepatoblastoma. So you'll have, the child will present with the enlarging abdomen. Non-specific symptoms will be there. There will be anorexia, weight loss, and jaundice can be infrequent in these cases. Sometimes the patient present directly with the metastatic disease. The most common place for metastasis in these cases is a pulmonary metastasis. Otherwise, it can metastasize to bone, brain, lymph nodes, eyes, and sometimes into ovaries also. The important thing you have to look for, as we see in cases of hepatocellular carcinoma, you have to look for invasion of hepatic vasculature, portal veins, and IVC. And if you notice a tumor thrombus or a non-enhancing thrombus, both have to be reported, and the entire extent of the thrombus needs to be explained and written in your report. So that is what I was telling you about AFP. It is normally elevated at birth and measures approximately 25 to 50,000 nanogram per ml, and they do not reach the adult normal level until the 6 months of age. So now when we have a case who has a mass lesion in less than 6 months of age, and we are confused between infantile hemangioendothelioma and hepatoblastoma, you now have to see if the AFP, if you do a single AFP, you might get, 10,000 value. But if in the serial AFP you have a falling trend, then you know that it might be because of the maternal, the normal AFP, which is now falling with age. And if it is an increasing trend, so now you know that it is because of the tumor. So AFP serial trend is important whenever you're dealing with a mass lesion and you're suspecting a hepatoblastoma in less than 6 months of age. If in more than 6 months of age, you can do a single value, and the single value, if it is more than, the normal value of the AFP, you know that you're dealing with the hepatoblastoma most likely. Then AFP level is also very important because it tells you about the metastatic burden and the extent of the tumor. So higher the AFP level of the patient, higher is poorer is the prognosis of the patient. So sometimes even up till 10 lakh, the values have been seen. And one very important thing that I want all of you to remember is that there are not all hepatoblastoma, the histological types of hepatoblastoma have an increased AFP. So as you can understand, it is alpha fetoprotein. So it is a fetal protein that is secreted by the hepatoblasts. So what is hepatoblasts? Hepatoblast is a fetal type of hepatic cell. So if that cell is not there, AFP will not be there. So that is why we're talking about the undifferentiated type of hepatoblastoma, in which the hepatoblasts themselves are not forming. So if the hepatoblasts are not there, then the AFP will be normal, but it will be a hepatoblastoma. Right? We have to do the serological and the immunohistochemistry markers to prove it to a hepatoblastoma. So this is a very important pointer, and that is why I put it in red, that all of you should remember, even if the AFP is normal and your imaging is suggestive of hepatoblastoma, you should still consider the possibility of hepatoblastoma in a child who is at least less than 2 years of age. Sometimes the tumor hepatoblast may secrete beta HCG and can result in precocious puberty, and it is mostly seen in boys and sometimes in females also you can see. So this is very important point again to be noted whenever you are dealing with these cases. So they can be single or multiple lesions, they can be hemorrhage, they can be necrosis, tumor in vein is very commonly seen and you have to report in your cases also. The hyperdense area that we were seeing on the CT were actually the areas of hemorrhage. Histology wise, we have two types, the epithelial types and the mixed epithelial and the mesenchymal types. So this one has a single cell type and this one has a dual cell type. So among the epithelial ones also, we have well differentiated form, moderate and the poorly differentiated form. Again, as I told you, fetal cells are the ones that are going to secrete the AFP. So well differentiated forms have a better prognosis and the poorly differentiated forms, they have a poorer prognosis. Then mixed epithelial and mesenchymal tissue, sometimes you can have this fibrous, cartilaginous, osteoid-like material within the epithelial component, and that is how histologically you can differentiate. So what about about treatment? The treatment can be surgery. It is mostly not done if the lesion is diagnosed to be a very large tumor, as it was seen in our case. Surgery is not done first hand. First, the patient goes for neoadjuvant chemotherapy, and when we are sure that the patient does not have any metastatic lesion and we are able to resect the tumor in entirety, then only the surgery is performed. Important thing is pulmonary metastases are not considered as an absolute contraindication to liver transplantation because these lesions are considered very sensitive to the chemotherapy. Then local recurrence if it occurs, we can treat with the RFA ablation. AFP levels have to be done in all follow-up cases because it parallels with the course of the disease. AFP can be a marker of early disease recurrence. So AFP levels that have failed to decrease by at least 2 logarithms during the initial therapy has a poorer prognosis. If the AFP is not falling with treatment, again, it has a prognostication value for the patient. So we have some poor prognostic indicators and we have some favorable prognostic indicators. So what all are the features that tell us that we are dealing with a poor prognosis of hepatoblastoma? If the AFP levels are less than 100 nanogram per ml, as I told you, if it is an undifferentiated form, it is more likely to be malignant, less AFP will be there, and that is why it is a poor prognostic sign. Then if it is more than 10 lakhs, as I told you, then we assume that there is a large tumor, there is a large metastatic load, and that is why the prognosis is poor. Then vascular invasion, again, because it reduces the chances of a primary resection of the tumor. And again, histologically, if the aneuploid nuclear content is more, then the chances of poor prognosis is more. What are the favorable prognostic markers? If there is a symbol, these all are, you understand, it is all related to the surgery. The earlier we are able to take it out and in entirety, that is the most important thing. So for favorable, we have a single lobe involvement or we have a pure fetal histological composition that we were able to see in the well differentiated form. And again, AFP levels, if they are between 100 to 10 lakh, then we know that we are dealing with a favorable prognosis and the child is considered that he or she might respond. So one tip that I want to give you is that sometimes you will see that when you send the AFP levels, they mostly write, if it is in the range of 5, less than 5,000, they write it, they give a particular value of 3,400, 4,300. But in many cases, you will see that they are just writing that it is more than 5,000. They are trying to tell you that it is more than 5,000, but it can be 1 lakh also. So if you are suspecting something, you are trying to treat the patient, you can ask for the exact AFP value because it is going to prognosticate your patient and it is needed for the follow-up for the patient. So do not go with the criteria of more than 5,000. Try to ask for the exact value of the AFP so that you can actually prognosticate the patient. So now we have come to some spotters and our first case is over. And how do I open both of them together? So 2 logarithmic levels is basically, a mathematical equation in which it should, decrease to 2 logs of the value. It is like if it is 1/10, if it is 1,000, then it should be 1/10. So that is what the 2 logs mean. So how do we, are you able to see the images of the spotters? So somebody has already answered. Dr. Dhruv, are you there?
Yeah, we can see the hip images.
But
21.
okay, I think I should share this. But I cannot see the comments along with this image. Why is it that like that? I cannot see the chat,
Yeah, I can see the chat. Everyone can see.
but I am not able to see. It is like the both windows are not working together.
Uh,
Right. Okay. Let's see what we can do. Okay. Somebody has given me an idea to log in through phone. Sure. Sorry for the delay. I'll just share my screen. Are you able to see the screen?
yeah, we can see.
Okay.
Recording in progress.
Okay. Yes.
Yes.
I think you have to turn off the.
Yeah.
You're echoing.
Is it fine now?
No, it's still echoing.
Now.
Yeah, okay. Can you see the chat?
Right.
Yeah.
So yes, somebody has told it right that this is synovial thickening in the left acetabulum. But is it synovial? What is the density or intensity of the synovial thickening? It is hypointense, right? So whenever you see synovial hypertrophy and it appears hypointense and you are seeing that there is some erosion of the cortex, you can see the cortex here, the hypointense line. And where is it here? So whenever you see a hypointense thickening with loss of cortex or cortical thinning or cortical erosions, you have to think about PVNS. What is PVNS? Please somebody give a full form to me. This is pigmented villonodular synovitis. So now we go to the next one. So this is a bone scan. What do you see? Right. So this is a metabolic super scan. So what does it tell us? It tells us that in the normal PET scan, you are always able to see the kidneys. So you can see that in this case, you are not able to see the kidneys. The kidneys are seen. Why? Because that is an area of normal contrast excretion. And in this case, we are not able to see. And why are we not able to see? Because the entire tracer that we had given to the patient has gone to the bones, to the lesions within the bone. So what are the lesions? So we can see some uptake here. We can see some uptake in the pubic symphysis. We have some uptake in the lower femur and upper tibial epiphysis. We have a dense uptake in the bilateral sacroiliac joint and the axial skeleton. So what is the diagnosis? Even if it is a, a super scan, what is the diagnosis? So that is also one area where you should know that. I'll just give you a hint. These are the symmetrical lesions. We are seeing symmetrical lesions on PET scan. So diffuse osteoblastic METs is not a diagnosis. Multiple myeloma is not a diagnosis. So I'll just give you the diagnosis. So this is a super scan because of the renal osteodystrophy. Oh, I have the answer. Sad. So this was a case of Poland syndrome in which you can see that this is the left pectoralis major. We do not see on the right side, and there is some deformity of the right chest wall. And this you can see the hypoplastic rib is also seen in the chest. So this was a case of Poland syndrome. Is happening. Right. So we have a next photo. What do we see? This patient has conductive hearing loss. That was the only history, and this CT, HRCT temporal bone was done. So everybody is writing FD, but I just want to tell you that FD, whenever you are saying, there should be expansion of the bone, and all of the bones will not be affected. So what are we dealing with here? We have a generalized disease which is affecting the bones. The bones have appearing sclerotic. Now give me a diagnosis. Right. So people have answered it is osteopetrosis. So you can see the sclerosis of all the bones which are seen in your picture, and that is why the patient has osteopetrosis was the diagnosis. This is the X-ray hand. What are you able to see? Right. So this one, everyone has got it right. What are the lesions that you see within the bones? So we have multiple lytic lesions, which we are seeing within the metadiaphygeal regions of multiple small bones of the hand. And these are multiple enchondromas, and we are dealing with a Wollius disease. This is again a common chest X-ray. What is the diagnosis? Right. So we have a particular vessel which is traversing from the right hilum up to the level of the diaphragm. So this is a Scimitar syndrome, also called as partial anomalous pulmonary venous connection. Coming to the next, what is this photo? What is the abnormality here? This is a CT chest, coronal view. Right. So we have a tracheal bronchus. The bronchus normally on the left side has a left upper lobe and left lower lobe bronchus. On the right side, there is a right upper lobe and a right lower lobe with the right middle lobe. So there is a bronchus intermedius which gives a right middle lobe and the lower lobe. And we have a separate upper lobe, and this is basically a tracheal bronchus. You can see that the bronchus is arising separately from the trachea and is supplying the right upper lobe. So this is a tracheal bronchus. So this is again a spotter. This is was commonly asked. This was asked in my PG time. What do we see? We see multiple lytic sclerotic lesions which are affecting bilateral, the bones, and we have this enhancing soft tissue that we can see along the cerebellum. What do you think the diagnosis is? What are we dealing with? Right. So somebody has answered it right. So this is Erdheim-Chester disease. So these are again a form of non-Langerhans cell histiocytosis. And so basically there is deposition of cells within the marrow leading to the sclerosis and the lytic lesions, and the similar deposits are also seen along the meninges. So this is how the Erdheim-Chester disease appears. This one is an easy spotter. Yes. So what do we see? We see the normal position of the Ryle's tube. We see the distended the stomach is here, and we see the displaced mediastinum towards the right side, and we see lots of air-filled cavities within the left hemithorax and no air-filled cavities in the abdomen. So what happened actually after the stomach, the entire small bowel, it went into the chest. So this was a case of CDH. This is the last photo. This is also an easy one. So we have, what do we have with us? I'll just tell you, we have a narrow pedicle heart. We have straightening of the left heart border. We have cardiomegaly, which is of the left ventricular type. It is down and out, not like a boot shaped. And what do we see is basically this double heart shadow. You can see one is this and one is here. So normally you only see the right atrium. If you see the double heart shadow, you have to consider what? MS, right? People have already answered. So this was a case of mitral stenosis. So this is mitral stenosis, and the appearance is called a mitralized heart. So now we come to the next case. Now this time we are dealing with a 10-month-old female with abdominal distension, and USG shows a solid cystic lesion, a solid cystic mass lesion in the right hypochondrium. I have both the CT and the MR this time, and I'll just scroll you for it and then we'll discuss the findings.
Recording in progress.
So we have an NCCT phase. We have, again, we have multiple contrasts. We have an arterial, venous, and a delayed phase. What do we see? Just scrolling it fast. Tell me all that you see. Again, we are dealing with a mass lesion. This is the kidney, which is displaced downwards. So let me see what you people have seen. So, okay, somebody has told me hydatid cyst. We have a cyst with septations. We have hydatid. We have some embryonal rhabdomyosarcoma. We have mesenchymal hematoma. So now I will discuss this case with you. So what do we have? So we start looking from the NCCT. So on NCCT, we have a hypodense mass lesion, and we have multiple septations. On post-contrast sequence, we see that these septations are enhancing. Whenever you are seeing a septated mass lesion, one thing that you always have to look for is the soft tissue. If there is any soft tissue within the cystic lesion. So the people who are saying hydatid, the child is a 10-month-old child. It takes time for a patient to have contact with a person who has a hydatid, or for hydatid to develop. So hydatids are never a differential in children of less than 1 year of age. So now that is out. Now we are looking at the other possibilities. So among the other possibilities, we had lymphangioma, and we have a mesenchymal hematoma and embryonal rhabdomyosarcoma. So I will first rule out embryonal rhabdomyosarcoma. Why? Because rhabdomyosarcomas are seen to be very aggressive in nature, and they are mostly soft tissue lesions. So we are not dealing with a predominantly soft tissue density lesion, we're dealing with a cystic lesion. Right, and on and in subsequent images, you can see that there is not much change within the density of the mass lesion. One thing which tells us that the lesion is a soft lesion is that you can see how the lesion is extending between the mesenteric vessels. So this extension actually confused me also, whether this was a lymphangioma or this was some other lesion. So now we go to the pointers that tell us that whether the lesion is or arising from the liver or arising from outside the liver. So again, we try to trace the, these are the hepatic veins. Then we have the portal system. Then this small part that we see was the gallbladder. And we have a small calcification also. I think this is, yeah, we have a small calcification also, curvilinear, that you can see in the NCCT also. And then as we come down, we see that the kidney is displaced. So now again, our differential will again be whether it is a so we'll just focus on one image. And how do I? Just give me 1 second. So we'll see it in a coronal plane. Always change your planes whenever you are confused. So now you have this lesion. The relations of the tumor. We see that the lesion extending right up to the subdiaphragmatic location, and medially and inferiorly it is displacing the kidney also, and it is displacing the small bowel also. So how do you tell that this is arising from the kidney or it is arising from the liver? So normally we discuss about the claw sign. So what do you see here is basically this is the compressed renal parenchyma. So if there is a cyst, and this is the normal pelvis of the kidney. So we know that this mass lesion is basically situated between the liver and the kidney. So our two differentials, whether it is arising from the kidney or it is arising from the liver, is differentiated from the fact that what is the condition of the displaced organ. If you try to see the liver, you can see that there is less of mass effect, but on the kidney, the mass effect is more. The cortex is completely thinned out. It is not involved within the mass lesion, but it is compressed. So do not confuse this with a claw sign. You can see that at the margin of the lesion also, the cortex is well seen. So whenever we are dealing with a cystic lesion of, for example, if we are dealing with a cystic lesion of kidney, which is occurring at the age of 10 months, what are your differentials? So we have multicystic dysplastic kidneys and we have cystic dysplastic kidneys with malignant degeneration. So most of these lesions, they arise from the pelvis of the kidney, and they have a communication or a content which is the part of the lesion which is invading between the renal pelvis. So that thing we are not seeing. What we are seeing is actually, you can see how this lesion is reaching up to the IVC, and it is involving, you can see the capsule of the lesion is almost continuous with that of the liver. So that is how we concluded that we are dealing with a mass lesion which is not arising from the kidney and it is arising from the liver. Now that we are in a position in which we can tell that we are dealing with a liver mass lesion in a 10 months old, now we have to make a different list of differential. That what is the list of the differentials? So you can see that it is not invading into any of the lesion. There was no metastatic lesion also, and rest of the organs are well displaced. It is, if it is a cystic lesion, it is looking like a benign looking cystic lesion. And we want to have the differentials of this case. So what are the differentials that we have at this stage? So our first differential always in any case is a cystic hepatoblastoma. Remember that hepatoblastoma is the most aggressive tumor in children, and we want to keep it as a differential. We just do not want to rule it out just because we did not have the suspicion. And that is why whenever you're dealing with any tumor in less than 2 years of age, hepatoblastoma, whether it is a cystic or solid lesion, will always be a differential unless you are able to rule it out, because that is the most gravest tumor that we have in this particular age group. So again, cystic hepatoblastoma, why are we keeping it in a differential? Because we have because there is some calcification, and again, it can have a purely cystic form also. Now, how do we differentiate? If the AFP levels are low, then cystic hepatoblastoma is ruled out in this scenario. Then there is some focal form of infantile hemangioendothelioma with myxoid change of the stroma. So one very important reason why I am discussing this case is because next, when I'm going to show you the MRI of this patient, you will know exactly why I included this case in the discussion, because it is the differentials that made people do what they did, and it was grave for the patient. Whenever you are dealing with a cystic lesion on CT, you always have to do an ultrasound for the patient. Why? Because the myxoid component, it appears hypodense on CT, and it gives the fluid attenuation. So when you do ultrasound for the patient, you are actually able to differentiate whether it is purely fluid or it is the myxoid content. The myxoid content is not fluid density on ultrasound. It is hyperechoic or hypoechoic and has a solid appearance. So this particular thing where you have a solid appearing lesion on ultrasound with no vascularity because it is myxoid area, and you have a hypodense cystic area on CT, you know that you are dealing with some myxoid component and it is not fluid. And when you see hyperdense, hyperechoic solid appearing tumor and appears grave on ultrasound, you know that you are not dealing with a lymphangioma. And that is why lymphangioma we had not kept in the differential of this patient, because the lesion was not cystic on ultrasound. And this particular characteristic is for the mesenchymal hematoma. Why? Because mesenchymal hematoma have myxoid tissue within them. So they appear solid on ultrasound and they appear cystic on CTs. But then what is your friend? You have to differentiate between the mesenchymal hematoma and the undifferentiated embryonal sarcoma, which is a malignant form of mesenchymal hematoma. So diagnosing a mesenchymal hematoma does not finish your job. Your job ends when you are able to rule out an undifferentiated embryonal sarcoma. So that they mostly occur in progression. So you all know that undifferentiated embryonal sarcoma occurs at the age of 6 to 10 years. So what does it tell us? It tells us that mesenchymal hematoma occurs at less than 2 years of age. However, that same patient can turn into undifferentiated embryonal sarcoma once the patient reaches up to the age of 6 to 10 years. So once you have diagnosed a case with mesenchymal hematoma, you have to follow up the patient up to the age of 10 years. A 10 months child has to be followed up to the age of 10 years, because the patient still has a chance of developing an undifferentiated embryonal sarcoma. And how do you differentiate between the two? The most common thing that we always talk about, a malignant tumor will have soft tissue and malignant tumor will have metastasis. So if in any of the follow-up patient develops a soft tissue which was not seen in the previous scan and you're dealing with a mesenchymal hematoma, you have to alert the surgeon, because the child might be developing an undifferentiated embryonal sarcoma and you have to do biopsy from that particular solid part only. The cystic area has mesenchyme, has myxoid tissue, it will not give you any result. You have to do the biopsy from the solid area if you're suspecting a malignant degeneration of mesenchymal hematoma. So once we are done with that, so infantile hemangioendothelioma also sometimes appears cystic when they have a myxoid change within them. However, in those cases, there are predominant calcification is there. Again, prominent vessels are there which are supplying the hemangioendothelioma part. And again, the lesion shows a centripetal filling, which was not seen in our case. Then, as I told you, undifferentiated embryonal sarcoma, is seen, the age group is not matching. Patient has 6 to 10 years of age, and because it is a malignant tumor, it can have hemorrhage or necrosis within it. Then again, cystic mesenchymal hematoma is a differential that we do not have anything against it, and it is coming in a differential. And we have to differentiate it from other intrahepatic cysts like simple cysts, hydatid disease, and abscess. And how do we do it? Simple cyst will never be so large in a child. Then hydatid, as I told you, there is a particular age group. If the child was after 1 year and we have some contact, then again, hydatid disease is a possibility. And then abscess, again, we have this, the double line sign that comes because of the differential enhancement of the wall of the abscess and the compressed peripheral tissue. So that is not an abscess. Now we come to the other cystic lesions that might occur in a similar location, and that is why we have to include them in our differentials. So we can have a choledochal cyst, we can have an enteric duplication cyst, we can have a mesenteric lymphangioma, and if the mass is pedunculated, right? So these are again the differentials of cystic mass that you can see in this particular area. So this was a case of mesenchymal hematoma. It is the second most common liver tumor. Age is mostly less than 25 years. However, most commonly it occurs in less than 2 years of age. In presentation is again as a painless abdominal mass with distension. AFP levels are normal, and predominantly it is a cystic mass, may appear to be solid or cystic. On histology, you will have mesenchymal proliferation with variable size cysts, bile ducts, and hepatocyte cords. There is a lot of loose mucopolysaccharide rich tissue, that whatever I'm referring to you as myxoid tissue, and that is why it appears cystic. It has a cystic appearance on CT, but a solid appearance on ultrasound. And how is MRI going to help you? That also we are going to discuss. Then hemorrhage and necrosis, if you see, then you have to think about malignant. So it basically, there is uncoordinated proliferation of the primitive mesenchyme. It is again a congenital lesion and considered a developmental anomaly of the ductal plate. It is associated with this particular translocation. And benign lesions usually have no malignant potential, whereas if you are suspecting an undifferentiated embryonal sarcoma, as I told you, you have to follow up the patients up to the age of 10 to 12 years. Then again, it is a malignant tumor and you have to look for metastasis. On imaging, as I told you, it will be a cystic mass, and the cystic portions are avascular and the stromal portions are relatively hypovascular. Then on very small cysts may appear completely solid on ultrasound. So before we go on to this companion case, I want to show what was done for this patient, and you will be shocked to see this. So what was done actually was that it was assumed to be an abscess, and pigtail was inserted in this lesion, and nothing came out of the pigtail, and it was just yeah, I can show you in detail also. You can see how the pigtail is entering into the cystic lesion, assuming that it was an abscess, and you can see the bulb of the foot. You can see it was inserted, and nothing came out of this lesion, and the child was, and it was a grave mistake by whatever outside the patient had got treated with. And this is why I am showing you this case, because these types of mistakes are never to be done by you. Always look at ultrasound and CT whenever you are getting a cystic lesion on CT. Please go and do an ultrasound, and if you are suspecting a mesenchymal hematoma, never insert this kind of pigtails. Are not to be inserted, even if you are considering the possibility of a lymphangioma. You can insert it if you are considering a lymphangioma. Hydatid also does not have to be intervened like this, but in this patient, this tube was put, and it served no purpose basically other than rupturing the mass lesion, and eventually this pigtail had to be pulled out. So this is what you have to avoid. As I told you that these are all myxoid component. So you will see that some of the areas of the lesion they are hyperintense on T1 weighted image because myxoid tissue it depends on what is the content of the myxoid tissue, the concentration, and because of that, the appearance changes on MRI. So you will have some T1 hyperintense areas if the lesion is myxoid. So MRI is better able to differentiate mesenchymal hematoma versus the other differentials that we were considering in a cystic mass lesion. So that is again one point that you should remember. If you are in a doubt on a CT, please get a MRI done. Do not do any intervention on children without confirming the diagnosis. So that was, I think, all about this case. So this is just a companion case, and you can see how the lesion appears. Again, this was a 2-year-old boy, and you can see that the lesion is cystic on ultrasound, and similarly, T2 hyperintense, we have thin septations, and on post contrast, you can see that there is enhancement of these particular septa. And again, this was a case of undifferentiated embryonal sarcoma, and now you can see how the lesion appears on ultrasound and how it appears on CT, on MR, sorry. You can see that it gives the appearance of multiloculated cystic lesion, but on ultrasound, it appears like a completely solid lesion, and that is the most alarming thing about any tumor, and that you might be dealing with a mesenchymal hematoma or a undifferentiated embryonal sarcoma. Whenever you have solid component, enhancing solid component, you have to consider a possibility of undifferentiated embryonal sarcoma. So this is just a small recap of, because we have discussed 2 liver cases. So I just wanted to tell you in brief about the various pediatric hepatic tumors. So we have hepatoblastoma, we will have raised AFP level, we have to look for associated syndromes. In HCC, it is mostly in the age group of 10 to 14 years. Do not diagnose HCC in less than 10 years of age. Unless the patient has some genetic predisposition. Then fibrolamellar, again a disease of the adolescence, patients will have normal AFP levels. Coming to the embryonal, these are the undifferentiated embryonal sarcomas, again seen in the age group of 6 to 10 years. Patient will have normal AFP levels. You will have myxoid areas, solid appearing on ultrasound, and cystic on CT or on MR. And then we have epithelioid hemangioendotheliomas. Again, AFP levels will be normal, and we have some centripetal fill-in. Embryonal rhabdomyosarcoma, embryonal of at any place within the body, they have to occur in less than 5 years of age. Again, patient will have a normal AFP level and will have a large, soft tissue lesion, which will be mostly malignant at presentation. Then infantile hepatic hemangioendothelioma, it is separate from epithelial hepatic endothelioma, and it occurs in less than 1 year of age. AFP levels are normal for age, and patient can present with high output heart failure, thrombocytopenia because of the bleed, and sometimes with hypothyroidism. This is one very important association that you have to know. The child has hypothyroidism and the liver mass, you have to think in the form of IHE, and if you are suspecting IHE, get the thyroid function test for the patient. MHL, as I told you, mesenchymal hematoma, it is mostly seen in less than 5 years of age. Patient will have a normal AFP level, and mostly it contains cysts. Then FNH, again, it is seen in young children and adolescents. Patient will have normal AFP levels, and females are more predisposed as in adults. Then hepatic adenoma, again, in more than 10 years. So more than 10 years, we have hepatic adenomas, we have FLC, we have HCC, and undifferentiated embryonal sarcoma. Rest are all less than 5 years of age. Hepatic adenomas are again associated with OCP use and androgenic steroid use. And again, important relation that we have is the glycogen storage diseases. So if you are having a child with glycogen storage disease, as I told you, you have to look for 2 differentials. We discussed this in hepatoblastoma also, and we discussed it in the hepatic adenoma also. These are the 2 differentials, but the age group is entirely different. So if a patient has glycogen storage disorder, if the child is presenting at less than 5 years of age, you have to think about hepatoblastoma. And the child is presenting at more than 10 years of age, you have to think about hepatic adenomas. So these are the 2 articles that I had referred for my talk. So this is now I have 2 bonus quarters. So tell me, please, this is again my exam spotter. I know all of you know this. Okay, somebody is asking, are you talking about this slide? I can share the articles also if you know, if you want, just telegram me or just mail me, I'll mail it to you. So yes, so somebody has told me the answer already. What is the diagnosis? Macrodystrophia lipomatosa. Right. So what is macrodystrophia lipomatosa? So as the word suggests, there is some macrosomia, there is some dystrophy, and there is lipomatosa, which means there is increase in the fat tissue. So what all do we have? So one important thing that I want to tell you is that you should not assume that macrodystrophy lipomatosa just has increase in the lipomatous component. It is actually the entire mesenchyme, the entire soft tissue, the muscles, the subcutaneous fat, the bones that are in particular dermatome, all of them are involved. It is just, do not get confused with the name of the lesion. It is, it is a form of a localized gigantism, right? So this is a very important spotter and a very common one also. So just remember it. So this is macrodystrophia lipomatosa. Not just the fat is increased in size, but the entire, all the things which are produced by the mesenchyme of that particular dermatome is enlarged. So that is why we have this entire finger which is enlarged, the soft tissue is enlarged, the bones are enlarged, and the muscles are also enlarged. So do not get confused by the names, right? So thank you. I hope today's session was, we finished on time also.
Thank you so much, ma'am. It was very helpful. Ma'am, there are 3 to 4 questions in Q&A if you would like to take.
Yeah. So I'll just. Okay, somebody wants to see the MR. I'll show the MR case also. So any other doubt? I'll show the MR case. Just I'll take 5 minutes and I'll show the entire MR case. We have diffusion also.
Someone is
Okay,
asking.
why was the
Yeah, someone is asking USG features of mesenchymal hematoma tumor. Please explain.
So mesenchymal hematoma can be a purely cystic lesion also, and it can have solid appearance also based on the myxoid content of the lesion. So it is mostly a cystic lesion with internal septa. That is the classical description of a mesenchymal hematoma. If there is a solid component, then it is undifferentiated embryonal sarcoma. Sometimes solid appearing areas are myxoid content. Do not confuse them. You have to put the vascularity and see what is the consistency of the tumor. And because the myxoid areas can also sometimes give this solid appearance. So why was the LV enlarged in the chest X-ray? Okay, that was not a pure MS. Most of the cases are associated with MS with MR. So in those cases, the left ventricle is enlarged, in which you have MS with MR, right? So ideally, in a case of MS, because the left ventricle is not getting much blood, left ventricle should not be enlarged. So in cases, mostly you will see that in RHT cases, both MS and MR are associated, and that is why the left ventricle was enlarged. But we say it as a mitralized heart. From where? So mesenchyma arises from the ductal plate, as we discussed. So pathology of hepatoblastoma again. So hepatoblastoma is basically abnormal proliferation of hepatoblasts. So that is the only pathology, and we have two types. We have we have epithelial forms and we have mixed, in which there is proliferation of epithelial as well as the mesenchymal forms. Again, we can have in the epithelial one, we can have well differentiated, poorly differentiated, and in mesenchymal forms, we can have some other tissue which is not liver within the tissue, within the mass lesion. So that is the mixed forms of hepatoblastoma. Okay, so I guess we should just go once to the MR that I was told to discuss. So I'll just show you. So I'll just show you what all I have. So I'll just show you first the T2 weighted image. So this was the T2 weighted image of the patient, and you can see this is the distended gallbladder, this is the liver. And again, we have a lesion which is extending right up to the subdiaphragmatic location and displacing the kidney downwards. We have multiple enlarged cystic areas within the lesion, and some of them have some hypodense content within, some of them have hyperintense content within, and some of them are purely T2 hyperintense. And we have this particular tube that we have placed, and this was actually, you can understand that this was actually a Foley's bulb, or that was placed within the tumor, assuming that it will drain the lesion. But obviously nothing came out of this particular thing. So once we have seen the T2, I'll just show you the other sequences. We have stir, and we have, just give me a second. We have stir, we have a T2, we have a T1, and we have this diffusion. Diffusion. I think we do not have diffusion for the upper part, so we'll just leave it. Okay, so I'll just show you what we have on stir. On stir, we again have this multiloculated cystic lesion, and there is no fat suppression within the lesion. And we can see the differential attenuation of the parts of the lesion. Then this is the T1 waist image, and we can see this is an out of phase. I'll just show you normality. So this is out of phase. Right, so we want to see if any microscopic fat was there, but again, it was not there. And we can again see that most of the cysts, they appear hypointense, except the few cysts that appear hyperintense. So there was also confusion in this case, whether this was a post-procedural thing or due to, it existed from before also, because patient had some bleed also. So my advice is always to do not intervene in cystic lesions before you know what the diagnosis is. And eventually, when the Foley's was put out and the sample was taken, so that came out to be mucin, and patient eventually was treated like a mesenchymal hemat. So coming back, can you please show a glance of 1 and 2 case? I think I have them. So what did we have in the first case? In first case, we have this lesion in the mediastinum in the right upper zone and mid zone with well-defined margins and ill-defined margins with the midline. On ultrasound, it was a solid mass, and on CT, we could see that the mass was solid mass with multiple chunky calcifications in close contact with the posterior mediastinum and the paravertebral soft tissue. And the differentials in our case were mediastinal neuroblastoma, germ cell tumor, and inflammatory myofibroblastic tumor, and it turned out to be a mediastinal neuroblastoma. And the second case.
Ma'am, we can't see your screen.
Okay. I'll show it again. Sorry. So this was the case. This was the first case in which we had this mass lesion, which was well-defined lower margins and ill-defined medial margins lost with that of the mediastinum. And on ultrasound, it was a solid mass with hyperechoic areas. And on CT, it was a solid mass with multiple chunky calcification in close contact with the posterior mediastinum and the mediastinum, the posterior prevertebral space and the mediastinum. And the differentials were mediastinal neuroblastoma, germ cell tumor, and inflammatory myofibroblastic tumor. And eventually, this turned out to be a mediastinal neuroblastoma, and we had discussed about the various neuroblastomas, and we did some spotters. And yeah, right. This was the second case. This was an elderly patient, 65-year-old, and we had some, some reticular nodular opacities in the left upper zone, and we have this soft tissue density, which we again see in the right upper zone and mid zone, with some pulling of the mediastinum towards the right side, and we were suspecting whether it was tuberculosis, whether it was silicosis, whether this patient had cement factory worker, history of cement factory worker. So we were discussing about tuberculosis, silicosis, and malignancies. So our first differential, because of the age, was primary lung carcinoma. Then we had kept a possibility of inflammatory myofibroblastic tumor again. We again had a possibility of progressive massive fibrosis with consolidation and some infective changes. I don't know if this will play. So this was again the case in which you can see that there was this sheet-like soft tissue in the right upper zone, multiple calcified nodes were there. So this was again, I'll just play the lung window also. This was a case of silico TB, which we had discussed. So I guess this was all. This was a complicated silico TB. So these were the two cases that we had discussed last time. And I hope all the doubts are solved.
Yeah, thank you so much, ma'am, for your time.
Okay.
Had a great discussion.
Thank you for attention. Thank you.
Thank you.